Hello, everyone. So, as Nigel said, my name is Eva Habib, and I had the privilege and pleasure of doing my practicum with the Fraser Health Authority, one of 5 regional health authorities in BC that provide services within the ancestral, traditional, and unceded territory of the Coast Salish Nations. I was hired with the Innovation Planning and Transformation, or IPT, team, who are expert consultants that manage high priority, large scale change initiatives and partner with leaders across Fraser Health to shape solutions and translate ideas into action. As a representative of IPT, I worked with 2 housing consultants from the Population and Public Health Department for this project. Homelessness and the risk of homelessness continues to increase across the Fraser Health region. Homelessness stems from an intricate interplay between economic and societal structural factors, system failures in healthcare and housing, and individual circumstances such as traumatic events, mental health and addictions challenges, or domestic violence. People experiencing homelessness present with mental, physical, and emotional challenges, combined with many other health related concerns, from neurological impairments to incontinence and trauma induced behavioral issues. There has been reported observations of the increasing number of people presenting with these complexities across the region, and meeting their needs has been challenging. With the lack of available and adequate housing, Fraser Health relies heavily on shelters and supportive housing sites operated by nonprofits to provide a place of stability for people experiencing homelessness. Many housing sites are unable to cope with the health demands of this population, and our traditional way of providing services is not working in meeting their needs. Services need more coordination as care is often disconnected, untimely, or inefficient, and the demands in service are changing with a growing population. In 2015, the Ministry of Health provided a policy direction for a better integrated health system of primary and community care. Many programs had been previously operating independently, making services difficult to navigate. One solution is to link fragmented services through specialized community services programs, or SCSPs. SCSPs are a redesign to the way Fraser Health provides services to key populations through an integrated and better coordinated system. Number of specific SCSPs for adults with complex medical conditions and frailty, moderate to severe mental health and substance use challenges, cancer care, and surgical needs. These programs are linked to primary care networks, which provide care around the needs of the patient using team-based care with a single point of contact. SCSPs are meant to reduce confusion and improve communication between service providers so that services are easier for patients, caregivers, and health providers to navigate. An issue with the way SCSPs are designed is that they are catered towards providing services to patients who are attached to a primary care network through a general practitioner. We identified a shared population of patients that are both complex medical and mental health substance use supports, whose needs are currently not being addressed in this redesign and who have a significant impact on the healthcare system. There are a number of adverse, untreated health effects due to homelessness, including spread of infectious diseases within crowded shelters and substandard housing, stress and trauma associated with housing insecurity and street life, which are all compounded by challenges in navigating the healthcare system. As a result, health issues remain unmanaged and eventually require multiple visits to the ER. In an attempt to remove silos of care within our health system, SCSPs have failed to consider this important shared population. So we asked ourselves, how can SCSPs provide seamless support for people experiencing homelessness who do not access health services in a traditional way? How can we work with those who are not attached to primary care networks? And how can we adapt the system to meet their needs? So our job was to investigate the needs of this shared population and to provide a list of recommendations to Fraser Health leadership to consider as part of their redesign. Our goal was to see how we could integrate the specific needs of this shared population to reorient services for those experiencing homelessness. We used results from a survey previously conducted by Fraser Health, as well as a Greater Vancouver Needs Assessment report to guide the development of 3 community engagement sessions. These sessions investigated the unique needs of each community to strategize on how to make services more coordinated. The purpose was to identify health issues that most impact housing organizations' capacity to service people experiencing homelessness with compounding health. Attendees from the community sessions included Fraser Health staff and leaders involved with the SCSP transition, housing staff, nonprofit providers, and people with lived experiences to determine what needs were similar to those identified in the literature, what priorities were different for each community, and recommendations for change. Some of the major themes that emerged from the engagement sessions included ineffective eligibility criteria to access health services, barriers with GPs, stigma, mental health challenges, lack of transportation to get to appointments, unstable housing, and a lack of preventative services. When considering program or service redesign as it relates to vulnerable populations, non traditional approaches to care, such as outreach access to healthcare, needs based rather than criteria based services, coupled with communication and consistency, are common themes that emerge to improve overall health. Based on this information, our team generated a list of recommendations for how to improve health services as part of the SCSP redesign to better meet the needs of the shared population. While our sky's the limit solution is permanent supportive housing that links both health services and housing to address the root problems of poor health and homelessness, the following recommendations were intended to bring forth a more public health perspective and specific consideration to SCSPs. We need to respond to acute and chronic health problems by redirecting attention to preventative health, by reducing structural and system level barriers given the number of health issues among this population that are treatable. The main issue is the need for more engagement in ongoing care. When left untreated, health decompensates, thus requiring more emergency visits. One of the most effective ways to deliver primary care to people who would otherwise not receive it is to bring primary care to them. A medical professional that can diagnose, prescribe medication, refer to specialists, and order health investigations is most appropriate to provide this care. This person would see both attached and unattached people and link them to a primary care setting once trust and rapport is established, or when they feel connected enough to advocate for their own needs in accessing services. Home support provides a range of community health services in order for people to live independently in their homes for as long as possible. While home supports can be provided to people residing in shelters and supportive housing, the current system is limited by scheduling structures, making it difficult for providers to respond quickly to clients with changing needs. A cluster care model is a method of organizing staff into teams to work with clients who live in close geographic proximity so they're able to meet the needs of clients who typically struggle with scheduling in a more flexible and timely manner. An important consideration to make here is when health authorities use language like home support in these settings. The use of this language lends to the normalization that shelters are pseudo homes, when in fact, from a public health perspective, they're considered failures in social policy. Homeless patients cycle through a revolving door of inefficient healthcare from the hospital to the streets and back again. A point person would be a consistent health provider who knows the patient's full history and can coordinate services and manage their case, which minimizes the client having to retell their story to multiple people. This person would be able to assist in navigating the medical system with testing, specialist appointments, and ongoing therapies as needed. Fraser Health acute care sites are seeing increasing length of stays for those experiencing cognitive impairment, homelessness, and addiction. These people who would otherwise qualify for assisted living, which are housing facilities for people with disabilities or for adults who cannot live independently, are declined based on specific behaviors such as smoking or active substance use. They often do not meet strict housing criteria, and their complex needs are too high for housing providers to manage. Low barrier assisted living would reduce the length of stays and ensure this population's health and quality of life are looked after. Places like these with designated health staff are more supportive in meeting residents where they are at rather than requiring them to meet specific eligibility criteria. For people experiencing homelessness, the manner in which they are treated by staff and the medical environment is crucial to health engagement. Feedback suggests that nonprofit housing staff have limited understanding navigating health services, and health providers have limited understanding of homelessness and the skills required to de-escalate stressful situations. Education and training could include understanding the impacts of the social determinants of health, effects of ongoing trauma and past adversity on health, knowledge around harm reduction, and understanding that many may prioritize their basic needs such as food and shelter over their health. Staff may be capable of dealing with some, but not all aspects of residents' needs, which also ties to education and training. A blended approach refers to programs and services working collaboratively and tapping into each other's areas of expertise to support residents and address their needs in the community. For example, a social worker could provide support and direction in social services as well as home health. I would like to end my presentation by thanking my practicum supervisor, Christine Stockdale, Kelly and Sue, the two housing consultants who I worked with for the duration of this project, as well as the larger IPT team for welcoming me so warmly to their department And a big thank you to Victoria and all of you, my MPH peers, for being so supportive for the duration of this semester and throughout the 2 years of this program. Thank you.
Fantastic, thank you, Eva. That was yeah, that was great. Actually, I'm going to start with a quick question before others, because I can do that, I guess, before others jump in, and that is, can you just tell me a little bit about the sort of, if you like, the transient nature, or it's sort of the short-term versus long-term um, homelessness, in terms of, is there sort of a steady turnover of people, or are there a core of people who are sort of long-term clients, if you like?
Yeah, thank you for the question, Nigel. From my experience, just going, we actually had a couple opportunities to actually go out into the community. This population is very well known to the housing sites that we connected with over the couple months of this program. So the people who are experiencing homelessness are very familiar to those going through our health system in Fraser Health. And it's actually kind of like a familiar faces program within our acute care sites for patients that are frequently visiting ER. So yeah, it really is kind of that revolving door, as I mentioned in my presentation, where we have the same kind of residents that are in these housing sites, or clients that are kind of coming in and out of the system, unfortunately.
Yeah. Thank you. That was very, very really interesting. And any questions from the audience? Victoria.
Hi, Eva, that was awesome. Thank you so much. One of the things I just wanted to hear more about a little bit was what you learned about the ways in which the public health system, I guess you'd call it, works with the rest of the health system, also called / illness care system, or not. You know what I mean? The two different groups. What was the connection between those? Because it sounds to me like your project was very much about how those two different worlds would interact.
Yeah, from a firsthand perspective of just seeing how these two different departments, like the department I worked for and working with the public health department worked, it's incredibly siloed. Unfortunately, there was a lot of challenges throughout this project. Just firstly understanding it because it's super complicated, but also because there's just not enough communication between the different departments, which is kind of ironic because the whole purpose of this redesign and program is to integrate a little bit better and improve coordination and communication. So there's definitely a lot of like barriers just from people's different priorities when they're working on different projects. So it was kind of really challenging, and to bring this like public health perspective to like why it's important to make these considerations as part of this redesign.